Hello, I'm Kimberley Golden, DNP student at Maryville University. Today we're going to talk about my project, which is decreasing the number of patients who leave against medical advice in the emergency room. On my committee is Dr. Tara Harris, my chairperson. My second reader is Dr. Rita Wunderlich and Esther Martinez, who is my community member. Let's take a look at some background information. Emergency rooms nationwide, they face a common problem. Didn't know this until started doing research here. Common problem is that there's an increased number of patients leaving before being seen against medical advice. Patients come into the ER and they're seen for what they actually consider to be an emergency. They're coming in wanting to be seen for that. And often these patients are placed in the lobby. They wait hours to be seen, where they actually leave against medical advice. And even sometimes they come in, we initiate labs, IVs, start imaging, and they still leave against medical advice. So, what are the risks involved? Your risks are mortality, increase, readmission. That includes length of stay even after the readmission, which are all negative clinical outcomes. So the aim of this project is to decrease the number of patients who leave the emergency room against medical advice in a 50-bed level 2 ER located in the southwest region of the United States, which is my facility. Okay, let's look at the review in literature. So there was there's three things that we are going to review, which is the rounding, the AMA forms, and de-escalating strategies. These are the things that I implemented in the project. The first thing, rounding. There was research that I found in a particular article, Pediatric Oncology Unit, had a 12-week study that showed 0 to 70% improvement for stays, and it actually decreased safety events. Things like this showed communication, how it led to better outcome. And they even did something called risk rounding, which is a platform for improving the communication. Rounding improves communication between not only the patient and the staff, but family members, between providers, and especially in a busy and complex environment like the ER, it is definitely needed to reduce safety events. The risk rounding not only just improves communication, but it decreases hospital-acquired illness by allowing those team members to voice what actually is happening in real time and give the risk and identify when they're rounding, they get to identify what is happening at that particular time. All of which risk rounding should take place in about 5 minutes. The second implementation was the AMA forms. Here, this is just basically informing of the nurse, the charge nurse, the patient advocate, and the provider. This approach is helpful to improving patient care. However, the ultimate responsibility of the AMA forms does lie on the provider and the physicians. They often are not trained too much in the approach for these patients, and AMAs are very time consuming too, especially when a patient is ready to go for them to leave. So understanding how to actually implement this was something we had to do within my facility, to have the nurses being educated on how to complete the form and letting the patient know why they are leaving that leaving against medical advice is actually not safe. So there has to be a systematic approach when patients want to leave. And our approach was uh, a charge nurse. We had a diagram that actually showed like you had to contact the nurse, the charge nurse, the patient care advocate, bring that patient to a secluded area where you can talk to them about their care. Leads me to my third um, review, which is the third implementation, which is de-escalating strategies. De-escalating, patients can get very aggressive when they're ready to leave. And these are actually tools that can help you diffuse those tense situations. Patients become frustrated, they can become angry, triggering patients wanting to even self-discharge themselves. They want to take out their own IVs and just leave because they're that frustrated. So because of that, offering a clear explanation of the protocol and the procedures, and being realistic and listening to the patient, and having effective communication strategies definitely helps with um, de-escalating these patients. Let's look at the next slide. So in this project, the theoretical framework resembled Kurt Lewin theory. Lewin's theory had a three-step model for implementing change. The first step was unfreeze. Unfreeze is actually the current situation. The current situation at my facility was patient wanting to leave. Okay, this would be the nurse or tech or anyone's response. Okay, let me take out your IV. You're free to go. So definitely that current situation needed a change. That moving to the second phase, which is the change, that's the moving phase. That phase takes place when you implement the rounding, the AMA forms being completed, the de-escalation strategies. So that's actually where change takes place. And then, of course, the freeze phase, which is Lewin's last step in this three-step model. And that's after the change has been implemented. Um, Finally, you show the decrease of the number of patients that left AMA from pre and post intervention. You could take a look at the diagram right there. Methods. So initially, the IRB, the Internal Review Board, um, which exempted human studies regulation, um, approved was approved by the hospital. Then the data collection sheet created by pre and post intervention, and that actually then you had the submission of the to the university for the IRB, which was also approved. Then you had the implementation phase, where that's when everything, the study, the project began. The researcher, which was me, I actually, this is where I planned the rounding of the patients, the completing the AMA forms, the de-escalating strategies, all to decrease the number of patients that left AMA. Then we had the meetings. And meetings, actually, I met with the ER director biweekly, actually held monthly meetings with the charge nurse just by themselves, held meetings also with the patient care advocates, and then as a whole spoke to everyone, including the providers. So that was the meeting phase. And then we had the collection of data from the EMR, electronic medical record, and the ER director, which is also my community leader, she collected the data from the EMR, and it was kept locked in the office with a password protected computer. Then On the slide here, it says researcher actually complied with HIPAA, which is the Health Insurance Portability and Accountability Act privacy. And I made sure that we protected the patients that were all in this project using a numerical assignment, just looking at the quantitative part of it. And then the data that was collected pre and post. So it was 15 weeks pre and it was 15 weeks post intervention, and noted that of all the adult patients that left the emergency room against medical advice. So those are the methods of how this project was completed. Sample. If you look at the diagram there, it shows where everything was, all the people were all in one. And then it separates like almost like a pie. So collected from the EMR, because that's where we got our data of those patients that were actually 18 years of older. So that's the whole amount. And so pre-intervention was the 14,937 people. So that's everybody. Where you see that pie coming out right here is where we're talking about pre-intervention, is where 604 patients left AMA. Okay. And then if you put that pie back together again, and let's look at post-intervention, everybody there, the sample size was 15,247. And then taking out that little pie area again was then 529 patients that left AMA. So this is how the sample was done. Data analysis. Now, with this project, we chose to use the lower tail z-test. And this is actually a hypothesis testing that evaluates whether the finding or associated is associated with this statistical that is statistical significant. This test can be used only if the population standard is greater than 30. So in the previous slide, we talked about the pre-intervention being 14,937 and the post-intervention being 15,247. So definitely those numbers, that sample size is greater than 30. And so that lower z-test can only be used if it's greater than 30, okay? Then if you look at the P is 0.0043, which actually is less than 0.05, which is a significant value. It is being illustrated here that the project had clinically significant evidence to show a change in one direction. And then the confidence level of 95% suggests a true change in ratio from pre and post intervention. All right, so then we get to the results. Okay, so let's look at the pre-intervention, which is on the far left. Pre-intervention, again, you see, and like these are pie charts, of course, and you see the red in area is the sample size, and that's the 14,937 sample of, those are the patients greater than 18 years old that left the emergency room AMA, and that comes up to 96%. And then you see the blue area here, which is 604 patients that left pre-intervention, which is that 4%. So let's look over here to our far right, which is the post-intervention. Again, the red area is the sample size, the 15,247 patients, which is 97%. And then the blue area here is 529 patients that left AMA, which is a 3%. So 3%, 4%, definitely a decrease is shown for the results. Okay, let's move to the next one. So limitations. Limitations. So let's ask the question, what population does the ER serve? Well, the ER serves all persons, including children and adults. Children and adults. In this project, the children were excluded. Okay. Um, so understanding after doing this project and just understanding, looking at the project, you realize that children have no control over leaving AMA. This study limited, didn't include the children, and they had no control. However, we looked at the the data that shows pre-intervention amount would have been 700 that left if we had included children, and then 591 post-intervention if we had included children. So definitely there is more significant outcome if we had included the adults and children. Um, and that last point there just talks about that minors and parents and guardians are the ones that choose to leave. Children can't make that decision. So they probably should have been included, and that kind of actually limited the study. Discussion. All right, so let's talk about this project here. So the DMP project findings, it showed that the number of patients that leave against AMA can decrease once there is an implementation we saw that in our data analysis PowerPoint, that it definitely decreases the amount, decreases if we include rounding, education, and education of course, of the AMA forms and so forth, and then using de-escalation strategies. So those are our findings. Now, in the rounding, the patient care advocates went out. They rounded on the patients every hour. The techs in the lobby actually updated the vital signs and reported abnormals to the triage nurse, the provider, the charge nurse. When it came to the AMA forms, the nurses knew how to obtain an AMA form. Remember the first meeting we had with staff, um, and asked, I would think it was like 38 people in the meeting, and asked how many people knew how to obtain an AMA form in the system. Only about 3 people raised their hand, and those were included just probably the charge nurses that knew how to obtain an AMA form. So we found that definitely there was a knowledge deficit among the nurses and the staff. Um, in the first meeting, that was good that we found it there in the first meeting, that knew even how to retrieve an AMA form. So educating the staff about it, how to complete it, um, was good. We actually had a laminated AMA form completed, and it was on each nurse's station. So they had something to look at in case, while they were filling out the AMA form, and what exactly needed to be filled out, and them knowing that it was the provider that was truly responsible of making sure that that form was completed or filled out correctly. Um, the The third thing, the de-escalating strategies, we also had a flow chart that said, okay, so the patient wants to leave. What to do when they ask to leave? So watching the culture go from, let's take out that IV, you can go home, to now watching them bring these patients to rapid care rooms, bringing the attention to the charge nurse, the patient care advocate, and all the persons involved in the care. It actually changed the idea of leaving the patients then. Instead of leaving, they wanted to stay and get care. So watching those three things being implemented definitely was a positive for this project. Altogether, teamwork, um, monthly meetings with the entire ER, they they believed in the project, which was great. We had biweekly meetings, as mentioned before. Um, I actually had the bi-weekly meetings with the community leader, Esther Martinez, and then separate meetings with the charge nurse. And all of this brought about teamwork and definitely a positive outcome that made some changes to our facility. Implementations for practice. So when patients leave, the quality of care for the hospital actually declines. Losing these patients prior to their visits actually results can result in more harm to these patients. So um, also we miss revenue opportunities for the healthcare system. Um, those patients that leave before treatment actually are markers for the emergency room performance. So performance levels not up to par when these patients are leaving. So the hospital also has to report Medicare and Medicaid and get paid for their quality data and metrics of those patients that they see. So patients that leave decreases those quality reporting to those Medicare and Medicaid services, and hospital lose money. Um, and that last point there, it is ultimately it's a financial loss for the hospital because those patients don't get billed for if they're not seen. So definitely there's a reduction in the number of patients that leave AMA actually will actually increase if we can prevent these patients from leaving. We'll see an increase in revenue and definitely improve healthcare outcomes. Conclusion. The project was statistically significant. Um, as the power of the study, 0.8360, which is considered high in strength, which is a sample size of 15,247 seen in the post intervention. Plan for the future is definitely the emergency department wants plans to decrease the number of patients that leave AMA. The momentum is there. We have teamwork going. The plan is actually to keep that momentum going. Have the managers discuss quarterly about AMA and the data of how the department is doing, and then have them do AMA testing um, where they use where each staff has to do AMA tests as part of their continuing education. Um, however, if I was to do this project differently, I would actually monitor it at night shift. I kind of did more in the day shift. And I would do this research in the summer. Summer seems to be the highest volume of patients that are seen. And I would definitely, as we talked about earlier, I would include children because they are a part of our population that we see in the emergency room. So I would definitely include them. And all of these elements, I'm sure, would definitely change and even make it more significant. The DNP project overall, the impact on me is giving me a sense, uh, giving me understanding of how to gather research, evidence-based research, put that research together, implement it, lead, and with my professionalism, step into the hospital, look at the problem that they're having, and increase the quality of care that we're giving to these patients. That alone brought a lot of fulfillment, and watching the fact that my project was statistically significant was very rewarding. This is me with the poster board I made in the ER. I took a picture beside it, and it just kind of on the far right when you're looking at the PowerPoint, to my far left in the picture, it had a little QR scan code that the staff could reach me if they needed to regarding the project. And I actually had on there some of the laminated AMA forms and the um, the laminated form that showed what to do when a patient wants to leave, who to contact, and kind of giving them a protocol of what to do. So thank you for listening. Do you have any questions? And I hope you enjoyed hearing about my DNP project. The last couple of slides are just my references um, that I used. And the last thing there is my contact email. Thank you.